On behalf of the Patient Safety Authority, I would like to welcome you to this web conference on getting past the policy, overcoming barriers to CAUTI prevention practices. My name is Angela, and I'll be your coordinator for this program. As a reminder, today's conference call is being recorded. And now I'd like to introduce our facilitator and one of the speakers for the call, Sharon Bradley. Sharon is an infection prevention analyst for the Patient Safety Authority. Sharon, you may begin.
Thank you, Angie. Welcome, everyone, and thank you for joining us for this webinar conference. Our program today features an excellent faculty representing best practices from both community and multi-system organizations. During the first presentation, we'll invite the audience to participate in a live anonymous poll on the typical barriers to prevention of catheter-associated urinary tract infections, or CAUTIs, as we will refer to them throughout this presentation. We'll also reveal the results of last month's statewide survey on implementation of prevention practices for these infections. Our program includes an overview of the risks and indications with Foley catheter use and strategies to overcome barriers to implementation of best practices. Our hospital presenters will provide their perspective and practical tips based on lessons learned from their facilities. Our objectives are designed to help you overcome the struggle to implement evidence-based practices and answer concerns your facility may be facing, such as which of the barriers to good practice is the biggest problem in your hospital, which of the ideas discussed could work in your facility, and what are the top 3 things you could do differently to make the biggest impact to prevention of CAUTI at your hospital. Despite evidence that CAUTIs and their accompanying adverse outcomes can often be prevented, these infections remain among the most predominant hospital-acquired infections. Between 12 and 25% of all patients in the hospital receive a urinary catheter during their hospital stay, and as many as 80% of all hospital-acquired infections can be attributed to indwelling urinary catheters. Simply put, overuse of Foley catheters leads to the frequency of CAUTIs. Patient risk increases as care becomes more complex. CAUTIs are an increasing problem outside of the ICU. Some studies indicate up to half of all catheterizations don't have an appropriate indication ordered, and almost 40% of attending physicians caring for patients who have unnecessary catheters weren't even aware that their patients had a urinary catheter in place. The indwelling urethral catheter is an invasive intervention that carries a real risk for patient harm. The 2009 Department of Health and Human Services Action Plan on Hospital-Acquired Infections has identified CAUTIs as a contributor to the growing concern of antimicrobial-resistant pathogens, and it includes CAUTIs as one of the most preventable causes of leading mortality in the United States. CAUTIs increase morbidity, length of stay, and healthcare delivery costs, which vary considerably. Most sources suggest that an episode of CAUTI will prolong a hospital stay for up to 1 day. The CAUTI cost estimate average is over $1,000, and if the patient develops bacteremia secondary to CAUTI, the estimates of cost increase to between $2,500 and $3,000 a case. Evidence-based ideas for CAUTI prevention are ready for action in real-world clinical settings. However, leaders and caregivers in many hospitals are still overwhelmed by these challenges and unsure of where to best apply their efforts. For any hospital-acquired infection reduction initiative to succeed, it requires physician and nursing champions who facilitate and support best practice at the bedside, commitment from senior management, and from hospital leaders who can demonstrate the importance of CAUTI reduction by encouraging your staff to actively participate in prevention programs and by holding them accountable. The new CDC Prevention of CAUTI Guidelines draft document was published this month for public comment. It lists clear indications for Foley catheter use in operative patients as seen on this slide, and it also demonstrates explicit links between the evidence and practice recommendations for all aspects of CAUTI prevention. This document also outlines additional guidance for hospital-wide use of Foley catheters, as you see here. These indications provide a framework to begin developing hospital-specific criteria for Foley catheter use. Given the risk of harm to patients with indwelling urinary catheters, alternative methods of dealing with incontinence, specimen collections, and uncomplicated short-term post-operative retention are recommended. A program today is designed to collapse the mountains of information located in the regulations and guidelines. We'll alert you to the most up-to-date significant prevention and implementation strategies and provide a roadmap for development of institutional policy and practices to address CAUTIs. The Department of Health and Human Services 2008 Action Plan to Prevent Hospital-Acquired Infections developed national prevention targets. The metrics outlined in this 5-year plan are built on the national infection rate, the associated costs and mortality associated with sepsis. These goals are not only based on CAUTIs, but also on the reduction of catheter usage as well. Results will be measured using NHSN data from reported infections and on administrative discharge data with the use of the present on admission coding system. Committee participants suggested that strategies to widely implement best practices in the prevention of CAUTIs be developed. Pennsylvania Healthcare Associated Infection Prevention and Control Act, or Act 52, was signed into law to strengthen standards and oversight around healthcare infections by promoting best practices, providing incentives to providers to reduce infections, and to provide clear guidance to healthcare facilities and providers. At this point, we will open the polling question you see on your screen. Which of the following is the most significant or the main barrier to implementation of recommended CAUTI prevention practices in your facility? Please check the box next to the main obstacle in your facility, and you'll have 60 seconds to enter your response. The results of this poll show that 41% of the hospitals lack of accountability for appropriate safe practices your main barrier, and second most significant barriers, active resistance prevention strategies in your hospitals. This type of survey can be useful to identify obstacles to bring in prevention to the bedside at your facility, and the remainder of this program will concentrate on the methods available to you to overcome these obstacles. Specifically talking about the barriers that you just identified, we need to ask ourselves why some hospitals appear to be actively engaged and committed to preventing infections, while some others appear very lackadaisical in their approach. Active resistance to change is a pervasive and significant impediment to translating research into practice in your hospital. Your organization can overcome personnel-related barriers by several methods. You can give feedback to your physicians and your staff of your facility-specific CAUTI data and compare it with national rates. Physician leaders can require mandatory compliance. Physicians who think they don't need to follow practices eventually will, when there's strong support from the medical director or the ICU physician. Selection of an appropriate physician champion who can speak the language of the staff they're trying to sway, and these physician champions also reinforce and model ways to improve. Strategies can be used that make it more difficult for resistors on your team not to comply, such as packaging components of insertion care into kits. A second issue is the insidious barriers to change which can be exhibited by your mid to high-level executives. These people can prevent or delay implementation. This problem can be overcome once leadership recognizes the negative effect it has on your staff. You can include the person early on in group discussions in order to improve communication and obtain their buy-in. You can work around the individual. This is a short-term solution. And you can take advantage of turnover opportunities and hire new people who are more likely to facilitate changes aligned with your hospital's organizational mission. Even when clinicians have the will to action, CAUTI elimination doesn't happen overnight. A successful program involves using a careful plan to apply new knowledge. As you see on this slide, assessing the problem and problem causes are important first steps before you go to initiating and identifying new CAUTI prevention strategies. Testing and process feedback is recommended to determine if the process is successful. APIC recommends doing a quick prevalence or snapshot in time study of risk. You can accomplish this with a simple counting of patients with catheters to determine, number one, the number of patients with catheters, also the average period those patients who have their catheters in place, and you can also look at your facility's primary urinary pathogen from your lab data. If you want to know more about your CAUTI rate, you can contact your infection control department. And for more details on determining the financial impact, you can use the link from our guideline slides to download the entire APIC elimination guide. This diagram outlines considerations when you're brainstorming and performing an in-depth analysis of the causes of CAUTI in your facility. It includes common causes of infections, as you see here, that are patient-related factors, caregiver-related, also your systems-related factors for hospital systems, equipment, or environment. This can be used as a starting point for your facility's assessment. To determine the educational needs of Pennsylvania hospitals, this is the survey we sent out to all infection preventionists just last month. The results here indicate that the majority of hospitals have written CAUTI prevention programs, and they have criteria in place that they communicate to the clinical staff. They also have a designated physician champion, which is really terrific, and annual competencies for clinical staff, as well as requiring a securement device for Foley catheters. About half of the facilities who've responded monitor physician orders for documentation of Foley criteria and also have Foley catheters, silver-coated Foley catheters in use. Prevention practices that were discussed are not implemented in most hospitals were the patient and physician education, incorporating of insertion checklists, criteria, and reminders into the medical record, daily documentation of necessity, as well as nurse-driven protocols. Once your team has identified specific process breakdowns identified from your assessment, you can develop protocols to adapt some or all of these prevention strategies. Once criteria are identified, they can be sent to your Department of Urology and to your Medical Executive Committee for approval. Catheter alternatives should be used or can be used in cooperative male patients who do not have urinary retention or bladder outlet problems. A sample physician reminder form, you can download this from the STAY compendium. A policy which allows nurses to discontinue Foley catheters that no longer meet your criteria is a known and very efficient method of getting the catheters out. Asepsis, of course, is paramount with these patients. As far as supply kits, how many times is technique broken due to time constraints of leaving the bedside to find additional supplies? Additional questions that you might ask your team would be, is there a process in place to document all aspects of Foley insertion and maintenance, which is where you would use this checklist? We're going to review the 5 items of routine maintenance to be documented daily, and they're basic asepsis, which is maintenance of a sterile, continuously closed system, keeping the collection bag below the level of the bladder, making sure that urine flow was unobstructed, and emptying the collection bag regularly, and using a separate graduate container for each patient, and making sure that the spigot does not touch the inside of the collection container. Has your organization established criteria for when a catheter should be discontinued? Do you have guidelines for use of a bladder scanner to assess urine volume prior to insertion of a catheter for urinary retention? Have you developed which process and outcome measures you will use for program evaluation and staff feedback? Are there mechanisms to educate patients and healthcare providers about use and care of urinary catheters? This list of tools can be used as you move forward with the implementation of your prevention strategies. A sample of an insertion checklist and other tools can be found on this link at the Health Protection of Scotland website. Information sheets and pocket cards are well-accepted tools for your staff. Poster contests can raise enthusiasm for your project. Our presentation today does include a decision-making algorithm and a formal compliance statement from your CEO for all stakeholders to sign is a good kickoff for a new, or if you're just revitalizing your program. You can also post pictures of surgeons washing their hands, pictures of your prevention team doing various aspects of care, and anything else you can think of to boost interest in your prevention strategies. Implementation strategies include starting with one patient and then one unit. You can require written verification that your criteria is met. You can build prompts and forcing functions into your physician orders to assure documentation at the time of the order. Empowering nursing and other clinicians to not proceed with catheter insertion when criteria are not met is almost one of the #1 methods of implementation. They can also contact the physicians to clarify and discuss alternatives at the time that they are not proceeding. Include a checklist in catheter insertion packs in a format that allows for easy documentation, like a sticker for the charts or a little card. You can measure an all-or-nothing process with the goal of assuring that all the items on your checklist are completed every time for every patient. Strategies that can also be implemented into hospital processes include working with your vendors and materials management. They can provide all your care items for urinary catheter care into a kit and make sure that they're available at the point of care. You can include a reference card with the proper insertion technique in your insertion kits. Your inventory records should be updated, and you can assign responsibility for someone so that the departments where catheters are inserted that frequently, such as your emergency department, have adequate supplies of alternatives, which we're talking about alternatives, which would be the intermittent and the condom catheters. SAE has published a fact sheet for patients, which is available online for you to download and use. Your educators can teach the core principles of catheter indications, risks, and alternatives to the staff. And this is going to open many avenues to the process of change. Verify documentation of those by routine maintenance every shift. You want to include Foley catheter necessity in your nursing assessment. If you have walking report, you can do it then at the start of every shift. You can also update your admission documents to include Foley catheter criteria, such as a check for presence and is there a proper indication. As outlined in the SAE compendium, all levels of hospital personnel have responsibility for prevention of hospital-acquired infections. Your hospital CEO and senior management are responsible for ensuring that the healthcare system supports adequate staffing of your infection control program and that the healthcare workers who care for catheters are competent to perform their duties. The best way to sustain process changes at the bedside is to focus on the staff nurse's perspective. Needed changes in care can be proposed by any of the clinical staff, and their ideas can be quickly tested through a rapid improvement process. Nurses can feel empowered in an environment like this, encourages them to think creatively about their work. Direct healthcare workers are responsible to practice appropriate infection prevention and control practices at all times. Hospital and unit leaders should hold their personnel accountable for their actions. The infection preventionist is responsible to ensure that there's an active program to identify CAUTIs and that evidence-based practices are incorporated into that program. They keep and analyze information on CAUTIs, and this information should be regularly provided to those who can use the information to improve their quality of care. Staff educators are held accountable for the development and provision of appropriate training education programs that also prevent CAUTI. In a survey of Veterans Affairs hospitals, 56% of hospitals did not monitor catheter insertions. 74% of them didn't monitor duration of catheter use. As the use of a catheter and the duration of catheter use are the most important determinants of CAUTI, the limited documentation of patient exposure to this risk is of concern. Elements and rationale for a detailed monitoring program are listed for you here on this slide. Easy monitoring tips include: look at all the patients who have Foley catheters and the documentation of insertion and care activities. You can measure that all-or-nothing process with the goal of ensuring that all checklist items are completed every time for every patient. Engage in additional process improvement cycles to refine the process and make it more reliable. You should provide feedback on your ongoing rate of success with bundle compliance to the staff. You can do this via your hospital intranet or streaming messages, or just by posting notices in the employee break room or on the nursing unit. Doctor's Lounge is also a good place to post these notices. Here you see the recommended formulas to determine CAUTI outcomes for your facility. These formulas are taken from the source that you see here on the slide. National CAUTI rates are available through the National Safety Healthcare Network, where infections are reported, to gauge a starting point for your facility. If you achieve reduction in CAUTI rates in the pilot unit, you should spread the changes to other units in the hospital where urinary catheters are inserted. And don't forget your emergency department. You can review cases of insertion that don't meet criteria. This, of course, will help you identify opportunities to educate and improve your program. Lastly, you should make sure to celebrate your successes along the way to keep your facility's program energized. And now we'll move on to our next speaker.